Okay, I want to talk about some of the conditions and things that come up from cancer, alopecia being one of those. And alopecia is just the term for hair loss. Patients will often lose their hair during chemotherapy treatment, as you may be aware. The best action that you can do from a nursing standpoint is educate the patient on this and allow them the control to deal with this. Some patients will opt to go get their hair all cut off themselves, and that gives them a sense of accomplishment that they are the ones that's doing it, not the treatment, and they feel more empowered that way. Another key important action is to allow them time to go to get the wig shop, go to some other support services that teach them how to handle, makeup and strategies, particularly for women. When they lose their hair, they often lose their eyelashes and their eyebrows too. So, trying to have some plans of how to handle all that and get educated in advance is always the best action for them to feel better about themselves during this time. Other things that can come from chemotherapy and treatments is pulmonary effects. These can be progressive and sometimes irreversible, which is not a good thing. But these are the typical symptoms that you would see: cough, dyspnea, pneumonitis, pulmonary edema. Um, Treatment is very much like you would expect for some of the other respiratory diseases we've already talked about. They may need bronchodilators, they may need cough suppressants, they may need to really organize their activities. Sometimes they may need to be on bed rest because they're so fatigued and so short of breath, and a lot of times they may need oxygen support. You can also have cardiovascular effects from these treatments. Patients that have radiation, that is radiation of the chest, like for lung cancer or for head and neck cancers, and also for breast cancer, if it is anything that's being treated closer to the left side of the chest, there is a chance that the radiation will cause truly damage to the heart muscle under the skin in that area, or later on they may develop some problems with that. There's also two drugs, doxorubicin or Herceptin, that are both really hard or cardiotoxic on the heart itself, and sometimes adjustments in dosages have to be done based on how well the patient can tolerate this from a cardiac standpoint. If somebody has had cardiac disease already, they are much more vulnerable to this. And patients will often, even years after this kind of chemotherapy, later develop heart disease at an earlier age in life because of exposure to some of these things. So they're usually followed throughout their life related to cardiac. I've already mentioned about reproductive effects. Patients will often want to find out all they need to about issues related to sexuality in advance and get some counseling up front. If they have had radioactive treatment to, like, their prostate with the seeds, or to their cervix, shielding may need to be used. And sometimes they may just feel that sexuality is not a big part of their life anymore, because if they've had, say, breast remove or other disfiguring things done, they may need some counseling really to help them get beyond some of that as well. Other things that you want to really be there for a patient who's going through cancer from a nursing standpoint is really to encourage them to discuss their fears openly with you. Again, like we talked about in class, there may be very few opportunities sometimes for their family to listen to them about the things that are really bothering them. So you want to make sure that you are there. Some of the treatment concerns, will be temporary while they're going through cancer treatment. And so letting them kind of understand that might not last forever, or that's just because you're on the treatment, is helpful to them to understand that. And sometimes they really need to get as much information up front to decrease their anxiety and not worry about things during this time. Infection is a huge risk for cancer patients, so it's one of our primary concerns when you're trying to prevent infection in these patients. Should always be part of their plan of care. These are some of the sites of infection you may often see. Most of those make pretty good sense. Blood infections are really can be also be pretty common, just because you do have central line catheters most of the time for this kind of care. They also can develop ulcerations on their skin or in their GI tract or their mouth that lead to infection. And of course, we've already talked about neutropenia and being at high risk for infection because of that, and or other invasive treatment that's being done. Cancer pain should be really treated like we've already talked about pain. Believe what the patient says it is. Really do as much as possible to really control aggressively patient's pain. It is really unwarranted to have a fear of addiction for cancer pain. They need to get what they need to keep it under control, period. Numerous drug options are available for pain management. And then there are other non-pharmacological things that can be done, and people should be encouraged to explore things like relaxation therapy, guided imagery, and aromatherapy, lots of things that help people deal with the pain better. I want to talk about just a few additional cancers briefly, just to kind of make you aware of a few concerns specific to them. There are a couple of hematological cancers, lymphoma and multiple myeloma, that were in your hematological book that we did not get into the other day, both of which usually require a bone marrow biopsy to really detect. And I wanted to mention a little bit about bone marrow biopsies because those are very common done. And you can see this Jamshidi needle that is on the right at the top picture. It is literally kind of a boring needle that is twisted and bored through the skin and through the bone itself and into usually the iliac crest, is where they pull out the bone marrow. It can be done in other locations too, but usually the hip is the main area that they're trying to take this from. As you can imagine, this is a high risk for infection type invasive procedure. So you want to always, first things first, you must have an informed consent regarding this procedure before anything else is done. Then the patient's prepped. This needle is a small openings put in the skin, and then this is bored into the bone. And then, as you can see in the bottom small picture, the needle catheter has an actual portal in the center where a syringe can be attached, and you can actually aspirate out part of the bone marrow. Because this is very painful, as you can imagine, patients are going to need to be pre-medicated with sedatives and are also going to need pain medications, as well as pain medications maybe for a few days afterwards of the procedure. Once this is done, you usually just have a little dressing or a Band-Aid applied, and you just kind of watch the site. But just remember, the main thing you've got to have is a consent before you do anything related to this. Lymphoma is a cancer that affects the lymphocytes. So the lymphocytes actually will develop an abnormal look to them and will not be good at functioning any longer. And there's two different types, Hodgkin's and non-Hodgkin's, and we won't go into a lot of detail here, but just know that Reed-Sternberg cells are a sign on a bone marrow that the person has Hodgkin's instead of non-Hodgkin's. And so you can see these pictures here for Hodgkin's lymphoma. The lower segment is just a highly microscopically enhanced viewpoint of the bone marrow cells. And in the center there, where this arrow is right here, you can kind of see these. You can kind of see that those particular cells are even more so abnormal. They don't look like the others, and that's the sign of Reed-Sternberg cells. The second kind of hematological cancer that we didn't cover is multiple myeloma, and just know that it is really a malignant disease of the plasma cells, and these plasma cells infiltrate the bones and the soft tissue, and they have become cancerous, and they will reside in the bone marrow. And what happens is they proliferate or grow in the bone marrow, and they really stay primarily in the bone marrow, but they push out or impede the bone marrow's ability to make blood cells. So that's a problem too. But it also is really tearing up the whole inside of the large bones themselves. And because this all takes place in the bone marrow, you don't see these cells in the peripheral blood to be able to know they're abnormal. So 2 other tests are used to diagnose multiple myeloma. They will have a specific kind of renal damage that causes this Bence-Jones protein in the urine that is detectable. And they also will show levels of M protein and serum hypercalcemia, meaning that a bunch of the calcium is getting pushed out of the bones because of this impact of growing cancerous lymphocytes in the bone marrow itself. And so patients are at high risk for spontaneous fractures. You can see this picture of the bone itself, and you can kind of see how badly infiltrated that is with other cells versus the normal look that it should have. And these patients are easily to have breaks of their bones and their blood counts be completely all off because you're not making the amount of normal cells that you should, because your bone marrow is damaged with this other process going on inside it. Other cancers, and I'm going to try to run through these pretty quickly. You can see the gentleman on the right. He has had radiation to his head and neck for a head and neck cancer, and he has got 2 different guys here, but the one on the right has got a very reddened skin, and a lot of times that's got to be really treated with some creams and lotions to soothe that, and happens with other radiation as well. The patient on the left, I just wanted to show you, this is an example of how a cancerous tumor can really grow and wrap around an artery. So this patient might end up being a DNR because there's really no way that this can be removed. And you will see some odd tumor growths on patients, so just be prepared to, watch your own emotions and your own reactions to some of these abnormalities. This is a cancer patient with GI cancer. You can kind of see how pale she is from blood loss. You can also see that she's lost her hair due to chemotherapy, and she looks very much like she's emaciated, like she's lost weight from this experience. So, nutrition would probably be something that we would be really looking at this woman for treatment, as well as fatigue. This is a stoma patient that's had intestinal cancer, and they have had their ostomy developed to kind of bypass where cancer has been. You want to make sure that you're really being careful about the skin in this area and keeping that bag very close to the edge of the stoma so that you don't get any of the gastric secretions eroding skin around the stoma. This is a breast cancer patient, just to see where they've had a bilateral mastectomy and then they've had reconstructive surgery. This is a lung cancer patient that is having, fluid pulled off his lungs so that he can breathe better from a palliative care standpoint. There's your pictures of ribbons. This is a prostate cancer, so you can kind of see what that looks like. Hopefully that gives you an idea of just some different things to review.